Top-Bed Talk.
Our next speaker in these lightning rounds is Michael Manning. He's assistant professor of anesthesiology at Duke University and director of research for their Perioperative Medicine Fellowship, and speaking on opioid-free anesthesia.
So, no disclosures for me, not yet anyway. Just to start off with a little cautionary note, the protocols that I'm going to talk about today really shouldn't substitute for good, sound clinical judgment, and I think you'll understand what I mean as we go through the talk. So, I'm a cardiac anesthesiologist by training, and about 4 or 5 years ago, I came out into the general side to do cardiac sick patients for non-cardiac surgery as part of a kind of a retooling at Duke. And one of the things that I noticed when I was working with some of the junior residents doing laparoscopic cholecystectomies, it's a great case, very predictable, nice short case, talk about cardiac physiology and the impact of the insufflation on cardiac physiology. I noticed that my patients weren't waking up the way I thought they would. They were kind of slow to wake up, very groggy, and acting more like a cardiac surgery patient. So that stimulated a little discussion in our group, and we undertook a quality improvement audit for how we were using opioids, because we kind of noticed a little signal, but we wanted to look and see if it was a true thing. So we did a randomized chart review, pulled 50 cases of lap choles at Duke between January 1st, 2015 and December 31st, 2015. And we were looking at intraoperative opioid use and recovery room opioid use. And what we found was, for an average of about an hour and 47 minutes, by far and away, our patients were getting an inordinate amount of opioids. Most were getting 250 mics of fentanyl, which just happened to be what the vial holds, and another milligram of hydromorphone intraoperatively. These patients would go on to the recovery room and get up to 250 to 300 mics of fentanyl. And so we kind of put our heads together and kind of looked at how did this happen? What was going on? So we did some observations in the OR, and we found that some of the contributing factors we thought was we were rushing the induction. You had the attending anesthesiologist pushing the IV medications, while the person at the head of the bed managing the airway was doing an inhaled induction, so we're double dosing. Once a tube got taped in, you noticed that the hemodynamics were on the floor, hypotension, so the practitioners would turn the gas down a little bit. They would get distracted doing what they're doing, setting up for the case, starting another IV, and surgery would start, hemodynamic response to surgical stimulation, and it was being treated with opioids. So we sat down and as a group said, okay, we need to improve how we use opioids, especially in the perioperative period, given the current climate in the U.S. with opioid abuse. So we sat down to educate and re-educate ourselves and manage our expectations for how we manage these patients. So we undertook a thought experiment, and we said, okay, our practice has typically been based on opioids for pain control. When patients fail opioids, what we do is we add an opioid PCA. Then we start adding acetaminophen, maybe some ketamine. Then we'll escalate and do regional. And then maybe we'll add some dexmedetomidine and some lidocaine. So what we did was approach this and flip this pyramid. So now we tried to standardize our non-opioid analgesics first, make sure that the patients get those first. In the OR, we will treat with lidocaine, magnesium, ketamine, dexmedetomidine as appropriate. And then at the end, if we need to, then we'll add opioids. We can use less and try to avoid some of the well-known opioid side effects. So this was the protocol that we, as a group, decided to do. We would start by giving patients gabapentin, Celebrex, and acetaminophen in the holding room. Where appropriate, we'd use a little glycopyrrolate to try to prevent the effects of ketamine. In the OR, we would substitute esmolol for fentanyl and give ketamine and magnesium as clinically indicated. And we encouraged practitioners to choose non-opioid analgesics first. It was left at the discretion of the practitioners. If you want to use opioids, that's fine, but do these maneuvers first. And what we found on the pilot, first 56 patients that went through, we were able to significantly reduce intraoperative and postoperative opioid use. Now, when we look at that in the patients 2 years prior to this protocol change to after, we had a significant reduction in post-operative opioid use during the hospitalization. We had a small improvement in post-operative nausea, vomiting. Hospital length of stay improved a little bit, but probably not very much because of the N. But we noticed that the PACU length of stay was quite dramatically improved. So about this time, we were approached by the urology team, the urologic surgeons, and they were particularly interested in changing how we managed robotic prostatectomies. They were noticing a lot of patients lingering in the hospital due to ileus, a lot of readmissions due to GI complications and constipation. And so they invited us to use this kind of a opioid-reduced pathway with them, and we said, okay, that's fine, but let's partner together and do this the right way. And so we undertook kind of an intense care redesign start to finish. So with pre-admission, at the time these patients come for contemplation of surgery, we asked and we provided the surgeons with a script. So we wanted the surgeons to outline the expectations for pain and pain management for their patients undergoing surgery. When they came to the pre-anesthesia visit with us, we would say the exact same thing, and we would educate and realign the expectations along the way. And we targeted patients that would have an increased desire and the motivation to participate in this. Patients that had comorbidities that you would want to shy away from opioids with OSA and obesity. Patients want to avoid the opioid side effects, and those patients with a particular history to nausea and vomiting. And so what we did was, this is kind of the realignment script that we gave them, and outlining what we expected their pain to be. 2 or 3 is realistic, a 0 is not realistic. We described the abdominal cramping from insufflation, the shoulder pain that they would have. We reassured them that this would go away. The script was also reviewed with the patients on the day that they were admitted in the holding room by the nurses, and then when we came to the bedside the morning of surgery, and we repeated it again. So now the patients have heard this 4 times. So our protocol for this was a little more intense. Our urology surgeons agreed to treat patients the day before with alternating doses of Tylenol and ibuprofen. The morning of surgery, they came to us, and where appropriate, they were given gabapentin, Celebrex, acetaminophen. We started taking caffeine histories for patients that came in the second case of the day. A lot of coffee drinkers in the audience, and you know that if you miss your morning coffee, you get a little agitated and a little irritated, and our patients were as well. So intraoperatively, we applied the same protocol. This time for longer cases, we're running a ketamine infusion and a magnesium infusion, maintaining with desflurane. And in the PACU, we selected, right before we wake up, it's at the discretion of the anesthesia team to give additional boluses of esmol, ketamine, or lidocaine as needed. In the recovery room, the analgesic plan was a rescue therapy with morphine or fentanyl. We selected non-sedating medications for postoperative nausea and vomiting. We also developed dashboards along with this so we could track the successes and the adherence to our protocols. And what we found was in those patients that went through that received no opioids by the practitioners, we saw a improvement in postoperative opioid use. Due to the low numbers, it's not significant. The postoperative incidence, or the incidence of postoperative nausea and vomiting, improved. What was a real win for us was the hospital length of stay, and the PACU length of stay was quite improved. Now, even in those patients that did get a little opioids at the discretion of the practitioners, we saw improvements in overall opioid consumption. We lost ground on the nausea and vomiting. but we also improved hospital length of stay as well as the recovery time in the PACU. Now, this is great, and it's a great QI project, and it hints at some very interesting data. So there's questions that remain and need to be investigated in a prospective way. So can this work outside of a laparoscopic case? Can we translate this to other surgical pathways? Is this going to improve patients' recovery? Can they get back into life a little bit quicker? Are they going to appreciate what is the patient's perspective of this? The initial feedback that we've got, which we haven't quantified, the patients that have undergone this therapy really like it. They feel a lot better. They feel more awake in the recovery room. They like that sensation. The feedback for the patients coming to the clinic, they feel like they haven't had surgery compared to the other times they've had surgery in the past. And so while I'll leave off with this cautionary tale, while opioid-free anesthesia may be the goal, I think there is a role for opioids in pain management. And I think we should, as practitioners with the opioid crisis as it is, I think we should look for opportunities along the care pathway where we can minimize opioid exposure in our patients if we can't achieve a true, absolute opioid-free anesthesia. Thank you.
Nick Majorison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.